And thank you. We have several things to get through. We have lots to get through this afternoon, this Friday afternoon. Before we get started, let's introduce who's in the room. I am here. I'm Stacey Howes. I am the Chief of Long-Term Care Quality Initiatives here at MHCC.
And I'm Jean Marie Gao, and I'm the Acting CON Chief.
Ben Steffen, Maryland Healthcare Commission.
Joe D'Amatos with HFAM.
Lori Sellens with Big Dallas.
Winnie Hawk with the Commission.
And Julie Beard with the Center for Long-Term Care Quality Reporting. Let's see, should I just read it off?
Yeah, just read them all.
Okay, and dialed into the meeting, we have Dana Kaufman, Paul Miller, Legislator Rosenberg, Ali Ludich, Allison Siborowski, Amanda Celentano, Ania Patel, Ann McKay, Anna Palmisano, Bob Kramer, Bonnie DePietro, Claudia Baylog, Dana Kaufman again, Dorinda Adams, Erin Davis, Heather Forsythe, Heather Reed, Hope Morris, James Forsythe, Joshua Auerbach, Kevin Hefner, Liam McGivern, Linda Cole, Lou Grimmel, Nancy Crawford, Paul Miller, Stevan Ellis, Teresa Brown, Teresa Lee, and let me just scroll back real quickly in case I missed someone who logged on. That's complete.
Before we start, Ben, did you want to say anything?
No, I think we should get started. I first off want to thank Mr. Kramer for being willing to talk with us today, and look forward to his perspective.
Thank you. So very briefly, in the last meeting, we heard from Dr. Atul Gupta, and he discussed private equity, and we learned quite a bit about private equity, how it works, how it can both be a positive and a negative for nursing homes. And we also talked to Shelley Martin, who discussed some of the negatives we automatically associate with private equity, but could actually be the result of other ownership structures. So they gave us quite a bit to think about and quite a bit to talk about in this meeting. Today we have, does anybody have anything they want to say that needs to be updated for the meeting minutes that I sent out last week? Anything they need to add before we move on? Okay, so we have
Question, is this meeting, I know Commissioner Boyle was not going to be able to attend, but I told her this was going to be recorded.
It is being recorded.
Okay, right.
We're recording all of them plus brief minutes. So we have a speaker today, Robert Kramer, from the founder. He is the founder and chair and fellow at Nexus Insights. We're going to have a question and answer session. I sent out the questions ahead of time, so please feel free to add in your own questions and contribute your own thoughts and comments to those questions as we go through them. And then we will review some of the concerns that the work group has already identified, and we want to discuss some possibilities for robust quality oversight. And finally, we'll go over the next steps. So
I would like to introduce Robert Kramer. Robert Kramer is the founder and fellow at Nexus Insights, a think tank advancing in the well-being of older adults through innovative models of housing, community, and healthcare. Mr. Kramer also is the co-founder, former CEO, and now strategic advisor at the National Investment Center for Senior Housing and Care. In addition, Mr. Kramer is a former county government official and Maryland State Legislature who was a leader for environmental issues while representing the state capital of Annapolis in the 1980s. Welcome, Mr. Kramer.
It'd be good to go off mute if you're the speaker. Thank you for the welcome. It's great to be with everyone today. Thank you for the invitation.
for being here. So we have our questions for you categorized by questions broadly about the nursing home industry, and then questions that are a little more specific to to private equity. We'll start with nursing home questions. What could Maryland put in place to limit the possibility of any bad actors entering the industry?
Well, let me say, first of all, wait a second. I'm getting an echo. Are others getting that too?
Can everyone please make sure that you are on mute?
And are you on mute, Julie?
I just muted myself.
Sound open.
Yes, Delegate Rosenberg looks like he is not on mute. But I don't see.
He is now on
Now
mute.
he is.
Is this-
Okay.
Is this any better?
Yeah, that's much better. Thank you. Actually, I'm still getting an echo, but I'll just continue as long as it's not a problem for everyone else. I'm not quite sure what's causing it. Are you all hearing an echo, or is it just me?
We
Yeah,
are,
yes, I'm
We're-
hearing it.
Yeah, we're hearing the echo. I think it might be the conference room. It might be echoing from the conference room.
Okay.
1 second.
Well, I think in terms of you're never going to eliminate bad actors, just as we don't in life and in any business. I want to distinguish, though, and take a distinction between what I'll call bad actors and poor actors. Poor, I don't mean poor in terms of how wealthy they are or how successful. By poor, I mean they're simply inefficient and they don't deliver well on whatever their business proposition is. And bad, though, are like we would say bad apples. Those who are bad from a moral perspective, because in this instance, all they care about is profits, and whether or not staff or residents' own health and well-being has to be sacrificed is not really of a major interest or concern to them. And those are bad apples. And that distinction is important because in an industry like the nursing home industry, where basically right now we have an old, tired, underfunded industry. The average age of a nursing home in the 100 largest metros in this country is 43 years of age. In Baltimore, it's 44 years of age in the Baltimore metro. The median age is 43. Think about that for a moment. Think about all the changes that have happened since we built those nursing homes. And I know that one of the issues you're considering are multi-bed wards, 3 and 4 bed wards. But again, that was de rigueur back in the explosion of nursing home construction in the 60s and 70s in particular. So anyway, just that distinction for one thing in terms of kind of saying, how are we? And again, I think it's really important for this group to think about the future and any actions you're going to take in terms of how that will impact the future. Why am I saying that? Because over the last several years, you've had a lot of, one of the reasons, I guess, for the commissioning of this working group is you've had a lot of nursing homes change hands. And why is that? Well, one thing is that Maryland has a, comparatively speaking, very low rate of MA or Medicare Advantage penetration. That's important because a Medicare Advantage historically pays 20% less on a daily rate than does fee-for-service Medicare. And they usually also pay for less days. So that's a revenue loss. And you have a low penetration rate of MA in this state compared to many other states where their penetration rates as high as 60 and 70%. Secondly, you have what's considered decent, not outstanding, but decent compared again to other states, Medicaid reimbursement. And thirdly, you have what I would call a relatively stable regulatory environment, which means there's some predictability. Doesn't mean it's good or bad, but there's some degree of predictability. The result of that, as well as some other factors totally outside of Maryland. For instance, Genesis during COVID wanting to conserve resources to a smaller and point them to a smaller set of properties, unloading about half of their portfolio in Maryland. And that was really driven by their internal business reasons, but it meant a number of homes in Maryland changing hands. For instance, in listening to Atul Gupta's presentation, which I had a chance to listen to, his data about PE ownership in Maryland, because it was the period of 2004 to 2015, is just way out of date. At that time, Manicare was a huge presence in Maryland, and Manicare was owned at that time, during that time, was acquired by Carlyle. Since then, the whole HCR Manicare portfolio was sold to a not-for-profit healthcare system, ProMedica, out of Ohio. Similarly, at that time, Genesis was owned by a combination of Formation Capital and JER. Again, like Carlyle, though not nearly the same size, private equity groups. Since then, that too has changed significantly. So one could say quite rightly that in the period of 2010 to 2015, it was a high water period for private equity concentration in Maryland in particular, because of Manicare being based here and having many properties here, also a large number of Genesis properties. But again, going to, when you think about private equity, even there are different, there are the really large private equity funds, so a Carlyle, a KKR, a Blackstone, a Fillmore Capital. And then there are and others owned by hedge funds, such as one that's now very present here in Maryland. But then you also have private equity that is more oftentimes individual high net worth investors who pool their dollars together to create a company and to go into a particular industry, in this case, skilled nursing. Very, very different from a Carlyle or a KKR. I'm not saying good or bad, but I'm just saying different. I noticed in the last meeting, there was some discussion about trying to define it by behavior. And one of the things there that Dr. Gupta, Professor Gupta spoke to was leverage buyouts and loading up with a lot of debt. Again, that's an issue that when many people, including the American consumer, loaded up on debt when there was fixed debt at 3%. That's why everyone who owned a home wanted to refinance. Today, obviously, it's a very different situation. When you have interest rates at 7%, the ability, let alone the likelihood of doing LBOs with 7% debt versus 3% debt is a really different reality. Now, all of that speaks to, I think you really want to look at the present situation going forward, not just simply so often with regulation. And I say this as a former state legislator, you regulate for what happened in the past, rather than anticipating what you're going to need for the future. And this is particularly relevant, I think, in the case of where you find yourself here in Maryland, where we find ourselves, as I speak here from Annapolis. Of those 100+ transactions, nursing homes that change hands in Maryland, I think there are 3 compelling reasons, at least, that would suggest many of them are going to change hands again in the next couple of years, for 3 key reasons. One, many of those acquirers, frankly, overpaid for what they bought. They just simply overpaid. They counted on certain trends, including cheap debt, which is now gone. And I think they overpaid. For instance, there was discussion often of lumping REITs in with private equity. Most REITs that are experienced in the skilled nursing sector have gotten out of it or have lessened their exposure to it. And if you listen to their earning calls, they say again and again, they can't believe the rates that some people are paying for nursing homes, and they would never buy at those prices. There's one significant REIT right here based in Maryland, Omega. And again, they've been diversifying their portfolio, but they still do own a good number of nursing homes. But overall, REIT exposure in terms of the skilled nursing sector has been declining, not growing. And many REITs that used to be 90% nursing home are now 40% or 50% nursing home. And for the most part, REITs have often been net sellers, not net buyers in the last 2 years of nursing homes. And so, so just some distinctions there. I said, I think many of these buyers that have come into Maryland in the last, let's say 2-3 years, one, have overpaid. Two, they're going to have more pain because we're going to probably see some sort of staffing mandates. Now, how that'll be, what'll be the lead time, but staffing mandates are likely to cause more pressure on homes just simply not being able to make their financials meet. And again, it's not just simply because of affording the staffing. It's also just simply because you can't meet a staffing mandate, you have to close beds. That means you're going to have less income. And as less income, you're going to become more financially problematic. And then the third thing is, because of COVID, basically the survey process, which is tied to the 5-star rating, was suspended for 3 years, with the exception of focusing on infection control. Quite understandably, the Fed said that's where we need to focus. So the surveys now being done are looking back not over the past year, but they're looking back all the way to beginning of 2020. So you have 3 and 4 year look backs. And I believe there a lot of issues are going to get found. So, you're liable to see star ratings significantly change, especially when you add then the staffing challenges that these homes have faced trying to find labor over this period. So 5-star system surveys, the issue of just simply overpaying for what they bought, and staffing mandates, staffing minimums. All of that means you're liable to have a lot of homes come up on the market in the next 2 years. So the issue is, who's going to buy them, or does the state want to run them? And then the other issue you have to think about is the impact on your overall healthcare system, and particularly your acute care hospitals. You may want to look at a Wall Street Journal article that came out earlier this week called "The Upheaval at America's Disappearing Nursing Homes" in charts. A lot of great charts. One of the things it points to is the issue that's being created in ERs and in hospital beds around the country, with the declining supply of nursing beds, and with many nursing homes not able to take folks because they don't have the staff. The result is people piling up, staying in beds when they could and should be discharged from the hospital, and the hospital wants to discharge them. As a result, longer wait times for a bed to open up in the ER. So if you suddenly have 5, let alone 20 or 30 nursing homes that are basically underperforming, and folks want to buy them, you probably want buyers to be able to be found, because if not, the hospitals in their area, there's going to be a boomerang effect. There's going to be enormous pressure on the state, executive branch and legislature to fix that problem. And so then you ask, where will the buyers come from? Not-for-profits are fleeing the space as quickly as they can. And when they're not fleeing, they're declaring bankruptcy, as the Wall Street Journal article points out. Secondly, government entities, local and county governments, are trying to get out of the nursing home business as well because they lose money. In addition to that, many, as recently as about 10 years ago, 50% of all the nursing homes in America were owned by someone who that was their only nursing home they had. It's still true that almost 1 out of 3 nursing homes are owned by someone who only owns that nursing home. There's another significant percentage that own basically 2 to 9. So there's what would be called small-sized operators. But for those folks, the money required for pay staffing increases, to pay for better training, especially since you need higher trained staff with higher acuity, the money required for the technology, for the air purification systems, to be able to capture data, all of these things, they don't have the size and the financial strength, so they're selling. So the question becomes, who will buy these? And I'm not saying you want to put up a sign, private equity welcome. I think you should be neutral. But that said, if you try and put up all kinds of barriers to new owners to make it as difficult as possible, understand you're liable to face a situation where, on the one hand, Maryland is suddenly saying, gee, we don't like this owner and their performance is getting worse and worse, but nobody will buy it. And that's going to put enormous pressure on your whole healthcare system. And also it's going to put pressure on the state to step in one way or another. So what would I recommend? I think transparency is important. Absolutely. And transparency of related business entities. Absolutely. So understanding ownership and ownership patterns are critically important. And understanding financial strength is important. But audited financials, for instance, penalizes the established company and invites somebody to go form a company brand new, because then they have no audited financials. And you're actually discouraging the experienced operator from coming in. So, it's just, again, they're just particularly the smaller experienced operator for whom doing that set of financials. And again, if it's a REIT, that's no problem. They're required to do audits. The vast majority of REITs are public. So just, again, unintended consequences here. The next thing I would say is look forward, not look back. I'd want to see a 2-year operating budget. I'd want to see how dollars are allocated. And then with that, I'd want to monitor that over the next 2 years, but not with a straitjacket. For instance, I saw one of the things on, I'm sorry, I'll stop.
I think we have some feedback. Someone needs to put their phone on mute.
Did someone have a question?
Go ahead, Bob.
Okay. Sorry. Okay. So look, 2 years of operating budgets provided for the entity coming in, transparency about their ownership models, transparency about related businesses. But on that 2-year looking forward, for instance, don't tie their hands. What do I mean by that? Keep them accountable, but don't tie their hands. Let me give you an example. Say you're taking over a restaurant, and a requirement, for instance, to keep all the current staff what if you discover you've got some great top performers there and you want to you want to reward that and reward them, but you've also got some people that everyone on the staff knows is not cutting it and that the rest of the staff is carrying them. So a mandatory requirement to make no staffing changes for a year or 2 years actually ties the hand of someone that says, yeah, there are some changes that need to be here, that need to be made. So, and what are some red flags to look for? Red flags to look for, to my mind, would be in those first 2 years after acquisition. If reported acuity levels through billings go up, but staffing goes down, that's a red flag. That looks like a coding game to me, where I'm upcoding the seriousness, the acuity level of my residents, but I'm not matching that with needed staffing. And that is a huge red flag. And again, there's a difference between inefficiency, just simply not. This is a really tough business to operate in. And some folks are good at it and others are not so good at it, not because they're morally bankrupt, but just simply because it's a really tough business. It's a business that basically prior to COVID was still primarily, particularly for frontline staff, a pencil and written report business in an era that is the 21st century of capturing data. Secondly, if you're going to be a SNF operator and survive in the future, you have to be able to work with more and more managed care organizations, more health systems, more health providers. To do that, you have to have real-time data, and you have to have it in a format that's easily understood and easily transferable. Many small, particularly small nursing home operations with 1, 2, 3 homes, the cost of doing that for them is prohibitive. So the biggest question is not how do we get rid of private equity? The biggest question is how, in a woefully underfunded system, do we address making sure that we're getting care and dollars to the folks that most need it, staff and residents. And so should Maryland require a lot? Absolutely. But don't make those requirements such that it basically says we want to discourage anyone to come in and buy this entity. Look at what's going on now in Rhode Island, as a for instance, or Massachusetts, where they're seeing a number of nursing homes close. Again, you may want to also look at Modern Healthcare, major healthcare publication this week, published an article by a reporter who writes a lot for Kaiser Family News called Bankruptcies Mounting in Troubled Nursing Home Industry by Diane Easterbrook. And again, that looks at just all the people getting out and all the homes. Basically, we've had about 600 nursing homes close in the last 6 years. And in some areas, some of those homes, in terms of their age, their decrepitness, it was a good thing they closed in terms of the quality of setting. But at the same time, what we're not seeing is a commensurate number of new homes being opened because it's so incredibly expensive. Yes, the consumer would rather be at home and receive care at home, and that whether it's home care or assisted living, they've boomed. But the average nursing home resident is long stay is very, very frail. And whether it's mental health, substance abuse issues, other cognitive issues, those folks are really hard to care for at home. And yet they're really hard for hospitals when they're using up a hospital bed and the hospital doesn't know what to do with them. And their psych beds are all filled to overflowing. So these to me are some of the challenges. I think, one of the questions I saw, should you take a positive view, a negative view, private equity? You should take a neutral view. unless you have a new capital source or the state wants to get into the business, which most states, again, are fleeing from, of running nursing homes. But you want to attract capital, but you at the same time want to have requirements for what that capital is going to do. And you want to understand who it is, and you want to understand their debt load. So let me stop there. I know you have a lot of other questions, but that was just a sort of just a brief. I shouldn't mention a couple of stats because I just checked sort of the latest data. About 5% in the nursing home sector as of about, well, basically as of the 1st of 2023 is owned by REITs. So it's about 5% of the sector. The numbers on private equity, because of all the challenges of definition of what is private equity, so forth, would most people would say would be between 10 and 15%. REIT size, as I said, ownership on the decline, and private equity, yes, has been increasing in some states, not in other states. Nursing home investment, by the way, is very much a state by state phenomenon. It's not really across the board. There are states that investors won't touch, and there are other states that they're attracted to. So again, let me stop there, open it up for either more of your questions on the questions you sent me or questions of the individual working group members.
Does anybody have any questions they want to jump in with, or comments they want to jump in with before we go? Next question. Okay. You started to talk about the landscape of nursing home care changing and the impact it has on nursing home investment trends. Can you talk specifically about what you think nursing home care changes regarding higher acuity of residents, how that is affecting nursing home investment trends?
Yeah. Well, again, I'm sure everyone here is aware that basically there are two very different populations housed in nursing homes. There is what's sometimes called the short stay population, which is a population for which, and those folks are rehab in one way or another. And they're most often been discharged from an acute care setting to now a nursing home as a post-acute setting. And the hospitals are eager to discharge quicker and often frailer and sicker. And that places a greater burden on that SNF or that transitional care center. But that short stay resident is there, that length of stay used to be often 20 to 30 days. It's more likely now 12 to 15 days. If it's Medicare Advantage as a payer, it's more likely 10 to 12 days, if at all. But that short stay resident is there basically to enable them to rehab, to get stronger from a stroke, from a hip fracture with other comorbidities that the individual has. And the payers there are usually Medicare or Medicare Advantage. In a few instances, private pay, but private pay, which means commercial insurance or just paying out of pocket, is only about 7 to 7.5% of the patient day mix in nursing homes now. And then, so that's your short stay rehab. And those folks, again, are being discharged quicker from hospitals and needing more support, whether it's wound care, whether it's very complicated medications that they're on. But the idea is to get them able to leave that nursing setting. It's a short stay. It's not meant to be their home. It's meant to prepare them to go home as quickly as and safely as possible. Then you have your long stay population. The long stay population is overwhelmingly Medicaid, a little bit of private pay, with folks that might have some type of insurance, long-term care insurance or whatever, but a very small piece of it, overwhelmingly Medicaid. It used to be that many of those folks there really, there was no reason they were there other than the fact it was the only place where they could get their long-term care paid for. Increasingly now, the whole private pay senior housing industry and the whole home care industry has grown up to provide alternatives to people to being in a nursing home, and for folks that really didn't need to be there. And so you've seen more and more dollars into home and community-based services and the whole growth of whether it's assisted living, home care, home health care, so forth. But that long stay population now, very high percentage with cognitive issues, very high percentage with substance abuse and mental health issues. One of the I guess, phenomenons during COVID was that I would say mental health issues kind of came out of the closet in long-term care, and they're not going to go back. Meaning it's a reality, and many nursing homes have not been prepared for this, let alone prepared for significant substance abuse issues, folks with opiate disorders and other types of substance abuse. So one of the fastest growing groups now, and groups where it's so hard to find any place to put them and where hospitals are often just so frustrated, are folks with high levels of cognitive issues, substance abuse issues, and mental health issues. And they're some of the hardest to place individuals. And again, with many other individuals seeking home and community-based services, this population is a growing population and very hard to serve, quote, in their home. If their home, again, most housing in America and a lot of housing in major urban areas is just not set up for efficient long-term care. So anyway, that's the kind of short stay, long stay breakdown. It's a frailer, much less mobility, and higher cognitive issues population in skilled nursing than it was even 5 years ago, let alone 10 years ago. Basically, if you are talking to hospital experts and nursing home experts, they would say that the residents now in nursing homes are increasingly folks that used to be in the med-surg units of the hospital in terms of their short stay residents. And so that's just a phenomenon. What does that mean? It has huge staffing implications. And that's why so much talk about staffing minimums and mandatory staffing levels and so on and so forth. But there's no question that the higher acuity levels, the mental health, substance abuse issues, the cognitive issues, and just folks even coming for short-term rehab with much more greater, higher degrees of medical complexity. It takes higher trained staffing levels, both in terms of number of staff and training of staff. So, that's kind of where the environment is today. I don't think Maryland is that abnormal in terms of its overall nursing home population. As I said, your homes, I mean, if you think about it, we basically, there have never been the dollars there to do the reset for our long-term care and including skilled nursing, but just as part of our long-term care sector. And our whole long-term care system in America has been built on the assumption that the primary care provider is the family, who is unpaid and untrained. And we're just now starting to shift some from that. But, we have functionally obsolete buildings. I mean, look at the issue of, for instance, 3 and 4 bed wards. Nobody thinks they're a good idea. But how do you effectively get rid of them and replace them? Understand, for instance, every loan on a nursing home is based on projections of revenue. And that's based on your number of beds that you're allowed to have times the likely revenue from that bed, done by a split in terms of Medicare, Medicaid, so forth. Those being the two primary payers. As soon as a home is forced to, let's say, because I don't think we have thousands of 3 and 4 beds in Maryland, but we do have some. And I know there was a question about how about getting rid of these, and I would say do it carefully and do it cautiously. Why? Because at a time when no one wants to have to go out and get a new loan, particularly if they have a HUD loan that right now is HUD insured at 3 to 3.5%. If suddenly they lose, let's say 20 beds, they've automatically going to violate the covenants of their loan. They will be out of compliance because they will have lost the revenue of 20 beds. And so what that means is, unless they get forbearance from the lender and HUD, they're
We have,
more than
someone needs to mute their phone again.
they're more than likely to have to either renegotiate or get a whole new loan at an environment where they won't get a 3% loan. They'll either get a variable rate debt or they'll get more like a 6 or 7% loan. So their cost of their debt, which is part of their overall operating costs, just went up significantly. So again, you looking to states like Oregon that did a methodical, thoughtful approach to how we can basically de-bed some of our nursing beds, particularly in terms of multi-bed wards. It's an objective that everyone would agree with. But the reality is, how do we get there without turning upside down the financials of the nursing home and forcing them out in the debt market at the absolute worst time to be out there? And ultimately, that's why I say, as you think about these things, you want to make sure you're creating options to attract good operators and good owners, not putting barriers up. Because if you put up barriers at a time of great dislocation in the sector, the beds are going to come back to you. And that's going to be a challenge. At the same time, the hospitals are going to be screaming that they need to get these patients out of these beds. And they want to know where in the world they're going to put them.
Excuse me, Bob, could you describe a little bit what Oregon did? I don't know that there are
Well,
many people.
now going back a good number of years ago, Oregon basically worked with both the senior living industry, by that I mean not skilled nursing, and the skilled nursing sector, but particularly with the skilled nursing operators to get them to voluntarily give up beds. And in essence, they paid them to give up beds and incentivized them to basically both close some of their oldest buildings, and in areas particularly where they had more beds than they needed. Now, this was a policy they started back in the 1980s and 1990s. And in the same time, they also incentivized the creation of more private pay, so to speak, senior housing beds, meaning assisted living. For instance, just to give you an idea, Portland, Oregon has the highest percentage of senior housing units of any major metro area in the country, and the lowest percentage of nursing beds per 75 plus population. Contrast that to New York City, where it's the exact opposite. Highest number of nursing beds per 75 and lowest number of private pay seniors housing. But in essence, the key to Oregon's approach was worked with the advocates, worked with consumers, worked with the industry, worked with the financial community to basically come up with a plan to incentivize operators to close these beds and to shift from that to other ways of providing services, whether through assisted living, whether through home care, whatever. And it wasn't a perfect transition, but it was one that got everyone on board and that worked. And now I will say that was in the 1980s and 1990s.
Chime in with comments.
We're focusing, we're now hitting a period with boomers turning 75 and older. And so the demands, coupled with what I mentioned with mental health and substance abuse and cognitive issues, where some would argue at a time when we're losing nursing beds, we're going to hit an inflection point very, very soon where we're really going to need beds. And quite frankly, that's part of what has attracted some of the investors paying what I would consider outsized and unrealistic dollars for the properties they've bought. I see a hand has been raised, so I'll stop.
Dana Kaufman has her hand up, and then in the room we have Joe DeMattos who has a comment.
Thank you. Just real quick on the issue with Oregon. Do you know, or in looking at this issue in other states, how they've also incentivized, you had said private pay for assisted living, but in the state of Maryland, honestly, private pay for assisted living puts many people out of reach too. It's very expensive. We do have a Medicaid waiver, but it has a very long wait list. And also the reimbursement is very low. Have you seen in your experience how other states may have balanced these two issues? So that was one question. And then I also just wanted to make a comment. The Hospital Association and MIMS are looking at the ED wait times in Maryland. I sit on that work group right now and at each meeting, and they've had two, but the hospital executives continually say the issue with trying to get residents back to nursing homes or in nursing home beds. It's one of the biggest issues they have. That is, well, I shouldn't say it's one of the biggest issues. It's one of the contributing factors in the boarding issues in EDs and the ED wait times, which Maryland has the worst ED wait times in the country. So I do appreciate your comments there because it's crossing over into another work group.
Yeah. Well, thanks for that comment, Dana, and thank you for your questions. A couple of things. One, interesting article came out, I think it was last week. I was on vacation until this morning, so I'm just catching up on some reading, but it came out in Health Affairs, I believe, leading health policy journal. And I think that's David Grabowski was one of the authors from long-term care expert. Basically, it was analyzing what's called the woodwork effect, namely in states that increased access to home and community-based services, including assisted living, whether or not that increased access led to a woodwork effect, meaning that they had much higher demand, whereas before the idea was if your only option was a skilled nursing home, you weren't going to petition for that. But if you had the option of assisted living or other home and community-based services, that would create what's called the woodwork effect of folks coming out of the woodwork to now sign up. And what this article showed and what this study showed, that Grabowski was one of the lead authors, was that there wasn't any real evidence of this, quote, woodwork effect, which has been the reason many states have chosen to have a very long waiting list and very few slots for HCBS or for a Medicaid waiver assisted living. And so I commend that article to you. David's also one of the fellows with me at Nexus Insights. In terms of what have states done, what I would say right now is we're in an experimentation stage. No one's proven yet what has worked and what hasn't worked. I've written at length on the issue of what I have termed the forgotten middle. There was just another major follow-up study released in Health Affairs this week on the forgotten middle. And those are people very much in that situation that you described, Dana, where they're if you want solid middle class, but their financial resources don't enable them to afford most private pays senior living out there, at least for very long, but they have too much in resources usually to qualify for government subsidy for the housing and especially for the long-term care. And so, the state of Washington has put together at the time, the first in the country, long-term care insurance plan at the state level, where with a tax basically on workers to help fund this. And I think you have to pay in for a minimum of 5 years. Now the benefit's not huge. Benefit, I think, maximum benefit is about $3,600 or something like that, which is not going to pay. Or I'm sorry, $36,000, which with an average cost of assisted living of depending on the area you're in, of anywhere from $4,000 to $5,000 a month. Obviously, $36,000 gets used up pretty quickly, but there are at least 3 other states looking at plans similar to Washington's. State of Washington, that is, in terms of a state-based long-term care insurance plan. There have been efforts at that at the federal level. They've all failed for one reason or another. There's not time to go into that. But I will say that to your question, Dana, I think one of the biggest challenges out there is what I'll call the forgotten middle. You have a group that can afford private pay, whether it's at home. The group most able to stay home are the most wealthy because they can afford not just 4 hours a day of home-based care, but they can afford to pay people for far more hours than that. And that group in the middle is going to be, and again, there was an excellent article by Chris, I think it's Roland, in the Washington Post a couple of months ago, and pointing out that, there was one woman who said, we did everything our country told us to do. And here we are now being told the only way I can get care for my husband is for us to spend down into poverty. And even then, we're just put on a wait list. I hope that's answers at least some. There was a lot in what you asked, Dana, but hopefully that's somewhat of a response.
Thank you. We have a comment from Joe DeMatos.
No, thank you, Stacy. Hey, Bob, thank you so much for the comments that you made. Joe DeMatos here in the room. Your and my thinking on these issues have mostly been in alignment for a number of years, and the breadth of information and knowledge you bring is deeply appreciated. Much of what you shared today was in HFAM's letter to HGO in March and to Ben Steffen and MHCC in April. So really appreciate that. And Dana, I appreciate your questions and comments as well. I'm very familiar with what happened in Oregon because it intersected kind of almost my entire career in public service. When you look at my state service, my association service, and my HFAM service. So I'm aware of it going back into the 90s. What I would ask for people to think when they think a theme about Oregon is to think about right place, right time for a person. Because that's what they did in Oregon over a period of 25 or 30 years, making sure there was the right place at the right time for that person. The right place, until you can't do it any longer, is home. And the intersection on whether you can do that or not is personal safety, your clinical needs, and your support system. And as Bob points out, there are socioeconomic factors with regard to support system, right? So we don't have an equal system of long-term care in this country. It is a system of have and have-nots. That's a national problem. We've got to solve that. But when you think about what they did in Oregon over a period of time, is they incentivized having the right place at the right time. So how did they do that? They worked with the sector and they reduced the number of nursing home beds, but don't get excited from a budgetary perspective because they really didn't save any money. Because what they did is they massively increased the rate nursing homes were paid for their days of care. So by a lot, the two highest Medicaid rates in the country are in Alaska and in Oregon. So they reduced the total number of beds. They paid the industry to reduce the number of beds. They more broadly used the provider tax, the provider assessment, and they created, as Dana points out and Bob points out, they created a lower income, middle income assisted living market. So they still had a robust, I've got money, I can go to a CCRC, I can go to a Cadillac assisted living, but through creating not a private sector equivalent rate, but a competitive rate in Medicaid for assisted living and incentivizing owners to create a competitive market rate. Again, with an expansion of the provider tax and a reduction of the total number of days of care in nursing homes, right? But they more than doubled the rate, the daily rate that they were paying nursing homes, right? So that's Oregon in a nutshell.
We have a question from Aaron Davis.
I guess not so much a question, but Joe, thank you for bringing up those social determinants and explaining what happened in Oregon, because that's the first time I had heard that, and that's a very intriguing solution to me. But wanted to reiterate, by the way, for those who don't know me, I'm from the MHA. I'm the Director of Quality and Health Improvement. Also sit on this hospital throughput, ED wait time work group. And it is a significant issue. It's not a new issue in Maryland. It's been going on for decades. But it's something that needs to be resolved. And we do hear it from our hospitals on a regular basis that post-acute is one of the contributing factors to that. It's multifactorial, but it is one of the contributing factors. And they are seeing it be more of a challenge to find placement, especially for our very sick patients. And in some cases, case managers are sending referrals to 20 different nursing homes and waiting 3 days to find placement. But I really want to appreciate what Bob has explained about looking towards the future and what do we do now, because we are already seeing the impacts in not just ED wait times and our length of stay in the hospital, but we're seeing it in quality too. And the other thing that I see our hospitals come to me with is that they are seeing, patients come in with decubitive ulcers and falls and things that they haven't seen in decades. It just wasn't happening. And so I just would encourage us all to really look forward and not create a bigger issue as we come up with solutions. So thank you.
Thank you. Ann McKay. Your hand up.
Hello, I represent residents that live in continuing care retirement communities, but my background is in geriatric nursing, and I worked as a director of nursing in a nursing home back in the 60s and 70s. And I guess thinking about moving forward, as Medicare moves to the accountable care organizations, we're concerned about what will the impact be here in Maryland, because that really changes how residents are going to be impacted with Medicare.
So is your question, Ann, about the impact of Medicare Advantage and what will that mean in Maryland if indeed it has a growing impact?
Well, not so much the Medicare Advantage, the Medicare's move toward accountable care organizations, which is different than the Medicare Advantage. And, people are finding out they're enrolled in these accountable care organizations and they don't really realize it's happened.
Yeah. Well, I'm not going to in terms of the ACO and particularly the accountable care, the ACO reach model, the new version that CMS has rolled out. You know, I don't want to speak as an expert on that. I think you raise a good question. Overall, though, I will say that I think without answering your question, I just want to be upfront and say, okay, this is not an answer. But your question and what goes behind it speaks to one of the ways in which we have to be thinking as a society, as a state, Maryland. How are we going to get more investment in the right places in our both healthcare and particularly in this case, our long-term care and our post-acute care system? For instance, in terms of the goals of value-based care, all of it requires you've got to have data and you've got to have systems and you've got to have people, all of which are basically, we don't have enough people, we don't have enough training, and you know, we've seen enormous pressure rightly on wages and what folks are being paid. Secondly, the data capture by the skilled nursing sector, it's improved a lot in the last few years, but basically it's, you know, data capture, healthcare has been behind areas like retail and hospitality, and long-term care has lagged badly behind acute care. But if we're going to have an integrated system that, to Joe's point, it gets the right, delivers the right care at the right time in the right place, we have to have data that's shareable. The systems that most nursing homes have are antiquated, and that's being generous. And they don't have good data to do. Without good data, they can't play in the new world of whether it's ACO reach, whether it's just overall value-based care. And so we have old buildings, which, for instance, we realize don't have the air purification systems they need to, have too many centralized entrances where we want to go to neighborhoods. We know that if we have neighborhoods where in an annual flu season, let alone a COVID or other infectious disease, where we can in essence isolate different neighborhoods, that's better for both staff and resident outcomes. But all of this requires funds, you know, whether it's the buildings, whether it's the systems we use, whether it's the data we capture, whether it's the people providing the care. So I guess my point is we're behind on all of those. So we want to figure out, we want the right type of capital, yet in the sense of capital that wants to do the right thing. Yes, capital is going to want to make a profit. But you know, it's got to not be at the expense of residents and staff. But that said, we need infusion of capital, and government dollars alone are not going to be enough. The whole reason I started the National Investment Center for Seniors Housing and Care back in 1991 was after my experience in the Maryland legislature and my experience in senior housing and long-term care. It was clear to me that we had to attract private sector investment, because if we were going to innovate, we were going to need private sector investment. And without that, there would never be enough government dollars. And that's 10 times truer today than it was in 1991. And so to me, we want to attract capital, but we want that capital to help really solve the problems that we've got. And those problems are real. So again, whether it's ACO reach, whether it's Medicare Advantage, whether it's the new primary care model that CMS unveiled a few weeks ago, we're going to see more and more efforts, I think, at the by CMS to basically get people get folks that I think CMS is increasingly going to seek to capitate the healthcare dollar spend and farm out that risk to other individuals in different models, and to say you're accountable. You have upside and downside risk. No one can take that risk without good systems and good data, and you're going to need good staff. And so that's the challenge in front of us. It's what I've dedicated the rest of my career to, and that's what Nexus Insights is about. It's innovative models to do this. But you know, I think what we need is we need to modernize a system that's still based on basically the 1960s and 1970s in terms of technology. And that's a prescription for failure.
Thank you. I think we just have time for one more comment question before we move on to the next agenda item. Howard Solins in the room.
Yeah, Bob, this is Howard Solins from Baker Donelson. I was looking at the work group identified concern slides, and I can see the reflection of the Dr. Gupta's participation. Two I've been thinking about have caught my eye. One more clinical and maybe is not your area, and the other is more in your area. Spinning off real estate from acquired homes, sometimes called OpCo, PropCo. We see you made a relevant point in relation to not-for-profits, which don't tend to have separate real estate entities. But if Maryland were to go in the direction of saying that in order to operate a nursing home in Maryland, you could not have a separate ownership of your real estate, what would be the impact, do you think, on the willingness of credible investors to come to Maryland and to invest the kind of capital you're talking about? And then the second question, it says, Dr. Gupta, for something I've done some looking and I can't understand where he came up with it. He used as a metric of quality mortality rates. And it's not part of 5-star, it's not part of, you know, I know that there's mortality and there's expected mortality and people don't go to nursing homes, you know, as places to die any longer, they go to be rehabilitated. But have you seen another state use mortality rates as a quality metric in a regulatory context? I didn't know where that came from, but that may, you know, just curious on those two concerns that were on the slide.
Well, I'll take the first one first. You know, again, my point is you want to have all the types of capital options at your disposal. The more you eliminate some, the less attractive you make it to any type of investor to come in. Why? Because an investor ultimately always has to think about exit strategy. How many folks are there? If I make this investment at some point, whether I have a short hold or a long hold, whether I'm in it for 3 years or whether I'm in it for 20 or 30 years, I want to know that there's liquidity in the sense of there are other types of investors that would want to basically take me out or buy this entity from me or this investment from me. And the fewer exit options I have, the riskier the investment is for me, which means either A, I'm going to put a higher return threshold on my investment. And that return threshold, then that jeopardizes the amount of money that go into operations, for instance. So basically, the more you reduce the types of investors that can come in, the fewer investors you'll attract. And as a result, it's going to be a challenging situation. Now, if you're in a market where everyone's dying to jump in and everyone wants to buy nursing homes and it's a bidding war, that's one thing. I don't think that's the market you're going to be in over the next 3 to 5 years. So, and again, as I said, I probably most every single person on this call has visited a health facility in the last year where there was one entity that might have owned the practice, another one that may have owned the building, and you may have gotten different billing bills from. And so the opco propco thing, whether it's in hotels, whether it's in all different types of healthcare, I don't think that's the issue. In fact, I would say it's a false issue. The issue is what you do with it. The issue is how you actually operate it. And now I've written and am well known for saying that too much of the senior living and long-term care sector tends to overvalue the real estate and undervalue the operations. And ultimately, it's all about the operator and it's all about operations. And so a lot of my work now is to try and basically get more dollars into operations and to get more recognition of the value that the day-to-day operator creates for that business entity, to get those dollars for systems, for data, for staff, recruitment, staff training, all those things that are needed. But the opco-propco structure by itself is not the evil or is not the barrier. It's execution. Your second question was on use of mortality rates. I'm not familiar with seeing it done that way because mortality rates have to be adjusted for so many different things. For instance, the difference between a short-term setting and a long-term care patient. You know, if it's a long stay patient, more often than not, this is their last home and they are going to die. And is this a home that takes a higher percentage? You know, if you have a high percentage of long stay Medicaid residents, you're probably going to have a much higher mortality rate than if you have a high percentage of short stay Medicare or Medicare Advantage. It's two totally different populations. One's coming here to go home. The other, this is their last home. So again, I'm not an expert on that area, but I would caution about using mortality rates because it really depends upon the resident population you're looking at. And to me, ultimately, I look at quality of life for the resident, for the family, and for the staff.
Thank you, Bob. This is Ben Steffen, the Maryland Healthcare Commission. I was trying to maybe synthesize your walking away point that at least I took, which was to think more broadly in terms of solutions to consider senior living models, of which nursing home is kind of the endpoint, but assisted living and senior housing also need to play a major part. I also wanted to ask you, the community-based services, it looks like that is being monetized now with entities like CareBridge seemingly really launching quickly and getting a foothold. That's the Bill Frist, Mark Smith initiative out of, I think it's Tennessee. It was ranked as the top fastest growing company in the Inc. 5000. I think last week it came out, but clearly community-based services with enhanced capabilities are going to keep people in homes, but clearly a Medicaid population's probably not going to be able to afford that. So am I off base? Rather than focusing only on nursing, focus on the entire continuum of senior housing is probably a better formula for dealing with these problems?
Well, I'd say the entire continuum of housing and care for older adults could broaden it even more. It's to Joe's point, we couldn't build enough senior care properties if everyone had to be move into a congregate care setting. That's not going to happen. We need to enable people to stay home as long as possible safely. And but we need to recognize that with increased longevity, we're also going to see increased rates of dementia. And we're already seeing soaring rates soaring rates percentage wise, because it starts from a small base, but in the area of mental health and substance abuse. So, that's recognizing that we need a whole system response that uses all the sort of arrows in that can be in our quiver. And that to me means one of those settings is the skilled nursing setting. It's by no means the only one. But I'm very concerned that, if just of the 106 or whatever it was nursing homes that have changed hands here in Maryland, if 1/3 of those are basically for sale within the next 24 months, my desire would be the vast majority of those get bought by somebody who comes in and really has a game plan for doing the right thing by the residents and the staff. And the wrong outcome would be they're left dangling out there in the market while it's clear the dollars and therefore the care that need to be going into that property aren't. And that's a situation that none of us, I think, want to see folks in Maryland placed. And that is a real concern, I think, because you've had a lot of homes that have changed hands. And I think a lot of those owners overpaid. And I think all that's going to happen in the next 12 to 24 months and what's ever already happened with the cost of debt, they're not viable investments anymore. And we've really got to ask the question of, okay, who can we encourage and how can we incentivize good operators and owners to come in to take over these buildings? Got to have a game plan for that. If we don't, shame on us, because I think you can see the handwriting on the wall.
Thank you. One small question. You mentioned MA. Do you see any enhanced role for the MA DSNP, the dual advantage products as being anything adding an especially important value?
Well, I think all the different areas of dual coordination, whether it's the DSNP, also whether it's PACE programs. There's obviously a new PACE center that I'm involved with as an external advisor, full disclosure, in West Baltimore. I'm a huge believer in PACE and in the PACE model, and I'm excited to see that new center going forward at Mondovan Mall. We need all of these options. It's not either or. We need all of these options, but doing a better job of duals integration. We have so many programs, and that's just duals Medicare, Medicaid. That's not to mention housing, where we have requirements and eligibility requirements for each of these pots, and they don't line up. And they're so often different. And it's so frustrating, whether the food is need, housing is need, healthcare, long-term care is need, but each eligibility pool for each type of service is different. So yes, duals coordination, DSNPs efforts, PACE efforts, they're going to be essential for the future.
Thank you.
Thanks. And Mr. Forsyth, I know you've had your hand up, so if you want to email me your question, since I guess we're out of time, I'll be glad to respond. I'm sorry we didn't get to you.
That's all right. It wasn't a question as much as a comment. And if I could just briefly say, you didn't think there were thousands of triples and quads in Maryland. Commission's data shows there's about 2,600 of them. And this is an amazingly large threat from a infection control perspective. you might know the CDC says we lost close to 2,200 residents of nursing homes during the pandemic. And COVID variants are on the rise again. So I just throw that out there for folks to be thinking about.
Well, I didn't realize
also-
the number was that high, so thank
It
you.
is.
But
It
that
is.
said, I'm just saying, whatever you do it carefully and cautiously, and work closely with the affected parties, because as I said, a simple requirement is easy to be enacted by the state, but when it trips all the bond covenants and basically their loan gets called, the problem's going to become yours. So just, it's important to think about that.
Yes, thank you.
Thank you for your time. I know that you had to leave at 4 o'clock, so thank you very much for your time and all of your thoughts.
Thank you, Bob.
Well, I appreciate the opportunity. It's good to see some familiar faces. And I think if I remember, Delegate Rosenberg, I think you and I entered the General Assembly in the same class and the same year. So you've had far greater staying power than I did. But it's great to see you again. And I was hoping to see Senator Bidel as well, whom I've also worked with for a similar period of time. But
How many terms did you serve?
I just served the one term. We had three
Okay.
small kids at the time and I loved it, but I just decided that supporting a family, raising a family, and having a political career wasn't something I was going to be able to do. But anyway, I
Pleasure being
truly
back together.
loved the time. Yeah, and great to see you. But
Thanks.
again, thank you all. I'll be glad to answer follow-up questions from the working group as well. But thank you for this opportunity to spend time with you. I appreciate it.
Thank you.
Bye-bye now.
Bye. So, Stevan, we did see your request for links and the resources that Kramer was talking about, and we will ask him for that information and distribute whatever we can to the work group once we get it. Okay.
Thank you very much.
We did see that. Okay, so over the past couple of work group sessions, we've identified some concerns.
Right, so this slide is on the work group identified concerns, and really what I've done here is just tried to capture what we have all been brainstorming about the last few meetings, and then check in with you guys to see if there's things we want to add or if we missed something. So we talked about the hiding of ownership information in acquisitions. We talked about reductions in staffing as being one of the red flags. Increases in resident, family, and employee concerns. We talked a little bit about the spinning off of real estate from the acquired home. And I think that this was in the context of, I believe Shelley had brought up where there were situations where the nursing home was then being forced to pay rent, like pay back rent on the facility, and then that was increasing and increasing and increasing, and that we should possibly look at if that was happening, like a cap on that. I think it was brought up in that context. Outsourcing key services was something that got brought up. Upcoding to increase revenue, possible decreases in quality, increased Medicare spending. So did we miss anything, or anybody have anything to add?
Can I just make a general comment? Yeah, just totally general comment. I genuinely and authentically appreciate this list. I would just, running through it, I would just make some suggestions. First suggestion I would make is that it can be difficult to identify all owners in a healthcare setting. I wouldn't necessarily call it hiding ownership information. I will say that it can be difficult to find all owners in a healthcare setting. I would say relative to outsourcing of services, that outsourcing and services in healthcare is a decades-long practice. It's not a new thing. When you want to look at that is outsourcing and the cost of outsourcing relative to related entities, right? So it's created in a perfect world to share costs. So an example of that would be back to Bob Kramer's ownership example. One lone nursing home probably can't afford a renal nurse or a wound care nurse. But the corporate entity of an owner that owns 9 or 10 nursing homes at the corporate level, which is a related entity to all of the nursing homes, can afford to hire a wound care nurse or a renal care nurse. And that nurse can then service residents and patients throughout the portfolio, which couldn't happen at any one of them from a financial standpoint. So to look at outsourcing key services, you've got to differentiate between what's been in existence for a long time and what's for a benefit versus not for a benefit in those related entities. Bob Kramer brought up a really good point on mortality. For people that come to nursing homes as their last home, you're obviously going to see a mortality rate related to their age, not related to their setting. So I would just offer those observations. Not every point, we don't go point. I know you're well-intentioned with this list. I take it as such, but I would bring those points up.
Thank you.
Yeah.
And Erin Davis has her hand up, followed by Stevan Ellis.
Hi, thank you, Erin Davis. I'd recommend that we also add impact on health system throughput and the ability to place complex patients requiring post-hospital stay.
Thank you. We'll add that. And Stevan Ellis.
I have several for the group to consider. No corporate accountability, fiscal transparency overall, cutting back in food and supplies, so not just the care concerns, and discharge planning concerns. So we're seeing those related to ownership changes and that sort of thing. So thank you.
Good points.
And the first one, did you say no corporate or new?
No corporate
No,
accountability.
no corporate
So all the
accountability.
responsibility of, often what I found from administrators, they tell me that they're being told by the corporations what they need to do, but the laws all govern the nursing home administrator, the director of nurses. There's not a law that really tells the corporation, that CMS doesn't regulate corporations, for instance. So that's just an example, if that makes sense to everyone.
Thank you, Smith.
Thank you. And I see that Dana has mentioned that different terminology for hiding ownership information could be disclosure of ownership information.
Mm-hmm.
Thank you. Anybody else in the chat? Steven, do you have your hand up again or? Oh, okay. Anybody else have it? Joshua Auerbach.
This essentially already come up in this little discussion, but for outsourcing and potentially for a couple others of these, a core part of the concern is affiliated entities. I mean, Mr. D'Amatos sort of talked about that too. Outsourcing key services to affiliated entities and the impact of that on the resources of the operating entity.
It's a good point.
Josh, just a quick point, and I know this is just identifying concerns for future discussions. Because I have worked with facilities that have affiliated outsourcing, like whether it's a therapy company or something else, or interest in a pharmacy. They will tell me oftentimes that they have better control over the quality of services if they have an investment. So I think it gets to the point that Bob, I think for future discussion, it's not, as Bob said, it's not the whether, but the how. And because obviously there's a legitimate concern if you're kind of forcing somebody to use something and then milking profits out in a way that works to the detriment of resident care. But just like the OPCO-PROPCO model itself is just a tool. And so too affiliated entities is a how, not a whether. But subject to further discussion, I know we could talk for a while about it.
Thank you. I also see Anna Palmisano.
Yes, thank you. I'd like to add to the reduction of staffing. It's not just the numbers of staff, but also if you reduce the salaries and benefits of workers, you may lose highly qualified workers. And we know that there's going to be a crunch in terms of staffing in the next, 10 to 20 years. So not just reduction of staffing, but also the concern about salaries and benefits. Thank you.
Thank you. Thank you.
Okay, so the next slide is on the possibilities for increased oversight. We tried to split these up between monetary and then some that are structural and staffing. So under monetary, we have requiring the person acquiring the facility to spend a certain percentage on patient care, requiring operated budgets be forwarded for the first 2 years, disclosure of debt plans to incur before, I guess I should say before incurring additional debt, increased surveillance of pre and post transactions, requiring a letter of credit or bond to pay for any future judgments, and creating a ceiling on rent increases if the facility is renting its own property. So well, let me go through the other ones real quick. Structural and staffing, requiring the removal of all triple quad rooms, creating a barrier for laying off staff for a period of time, the prohibition of NDAs for staff and residents, and the enforcement of current legislation, surveys, inspections soon after acquisitions. And that comes from something that Senator Bidel had brought up in a previous meeting where there was some previous legislation that was passed. Was it 2021?
Yes.
2021. So that was what that bullet point is from. So I want to pause here to make sure that that we haven't missed anybody's ideas, or if you guys have other ideas that you want to sort of put out there on this list.
Dana Kaufman.
Yeah, I just want to clarify, is this just a list for discussion or a list for recommendations? I mean, this is just for discussion right now, correct?
This is a list of just for discussion. These are topics and suggestions that have come up throughout the work group discussions
So far.
that we
Okay,
put in one
and this is
place
just
for
based
further
on
discussion.
and this is just for on acquisitions.
Yes.
Okay, thank you.
Yeah, the only other point, I think it's a pretty complete list. I just would, it comes up again after Bob Kramer's, all of his sort of concerns and thoughts on being very cautious about these steps. So, we'll all deal with this together with all of the inputs.
And Winnie?
Yeah, I was just, this is Winnie Hawk with the Commission on Monetary, the last bullet, create a ceiling on rent increases. Is it limited to rent increases, or is it really a broader discussion of like the fees that maybe are imposed subsequent to a private equity or whatever kind of an acquisition that occurs? So some of these are really specific, and maybe you just need to look at what are the implications from potential, and that is perhaps the rent that goes into acquiring a property, selling off the real estate, then having a fee or a rental fee. Could be any kind of a fee.
They're called escalators, by the way.
Escalators.
Yeah.
Escalators.
Escalators.
Right, and that was something that had come up as part of when Shelley was here and Joshua and Shelley had done their presentation. I don't think Shelley's on the call, but Josh is. Is there anything that you wanted to add, Josh, about the ceiling on rent increases?
don't think so. And on the subject of the OPCO, PropCo, as we're calling it here, one of the concerns that we talked about the last time, and I think it really was a question.
From this morning?
Yeah.
The
There's a soda in there if you want to.
No.
whether it from the enforcement perspective, if the PropCo is accountable for what happens in the facility, and if it is not, whether there's a risk that there's no one accountable because the OPCO has less substance having no property. I mean, I think there may be responses to that concern, but I guess I wanted to reintroduce that concern associated with the landlord-tenant stuff.
We have a lot of people with their hands up, so we're going to try to get to as many as we can. Allison Siborowski, do you have a question or a suggestion? Allison?
No, I'm sorry, I don't. I'm not sure. I did not mean to raise my hand, so I apologize.
Okay. Claudia Baylor.
Hey, thanks. So thinking about this list, and thinking about Robert Kramer's, discussion and sage advice on sort of moving cautiously on anything, and I realize these are all just discussion points, but it seems to me like for many of the things on these lists, both monetary and structural, I think it's helpful to kind of have a baseline understanding of what is currently divulged in the universe that we're talking about right now. So this is a work group dedicated to looking at future acquisitions. But I do think it's important to understand if we're going to discuss something like, well, should the state require a certain spending percentage on patient care? What is the current percentage of spend on patient care in our facilities, and particularly in the 100 or so that we could identify as the most at risk for future acquisition or to be put on the market. Or if you're looking at rent increases on facility, again, in those facilities, what are we looking at as the percentage of rent payments that are increasing to the detriment of resident care or staffing? So I'm just sort of like thinking about this list and just throwing in as like a discussion point that there's sort of a level of understanding that I think we want to have based upon available data, based upon cost reports, but a level of understanding that we have of like, how are facilities operating right now, particularly, this universe of potentially flipped facilities in a market 2 years down the road.
Thank you. Erin Davis.
Yeah, thank you. So one of the things I'm looking when I'm looking at, I'm thinking is, making sure we put the patient in the middle of this and really focusing on the quality of care that's provided, before, during, and after the acquisition. And that may not be coming up with new or increased oversight, but I think some of that may be making sure we're on the right path to getting surveys on time, making sure that there's transparency into the operations and quality in the facilities.
Thank you. James Forsythe. Mr. Forsythe.
Just quickly, the prior comment that these possibilities for increased oversight would only be addressed to acquisitions, I would suggest the work group should go further, since its mandate, I think, as I understand it, is to also address private equity issues. And I've done a dive into the commission's database, and I find that only 6 private equity firms are responsible for about close to 80% of the triples and quads in Maryland. So my hope would be that the work group would also consider what to do about the problem of triples and quads and existing facilities, not just limited to acquisitions. And I say that with a sense of urgency because clearly triples and quads represent a public health danger in a time of potential renewed pandemics, and the fact that they are so difficult from an infection control standpoint. So I just wanted to say that piece for what it's worth to you. Thank you.
It might be valuable, probably not in the next 15 minutes, but to categorize some of these, whether they would apply to everyone. I do think that things like putting the equivalent of an actuarial value on the percentage of revenue spent on patient care would be tricky and probably unfair to apply only to acquisitions and might lead to other distortions in the market. So I think staff should think about this a little bit and say categorize these a little bit more finely, because I hear what Jim is saying too about triples and quads. If you're going to take action, it's a little hard to do that only on facilities that are being sold.
Or someone said you have your hand up.
Just two quick points. These are more observations because I'm not a member of the board. Jim, you and I can have a separate conversation about infection control and triples and quads. I'm involved in that issue in other states and have looked to the lack of any data that there's an incremental increase in risk in a 2-bedded room versus the 3-bedded room, recognizing that nursing home residents don't lay in their beds in a static way, at least I hope not. And that they interact throughout the entire facility, and the lack of data on a correlation between all the mere fact of triples and quads and infection control. But that's another subject for another day. The other thing this is just an observation, and obviously I come with a certain perspective. And that is thinking about Bob's comment about kind of a neutral view of factors and a deliberate and thoughtful approach. When I look and see letter of credit or bond to pay future judgments and prohibiting NDAs, if I were a plaintiff's lawyer, or did malpractice defense work, and I do neither, I might like that. But in terms of, I would just ask that when the group thinks about that, they're thinking about it from the perspective of kind of public policy and a regulatory environment, as opposed to advocating for an environment relative to whichever side of the fence you're on relative to litigation strategy. So that's just a reaction, to those two message points. Just making sure that they're policy oriented, not kind of picking one side over the other relative to litigation strategy. Thank you.
All right, so the next topic that we would like to address is quality. This slide is mostly a reminder of what we've shared with you before. So it goes over the quality standard that we have in the current certificate of need. So this is our current authority. And when someone applies for a certificate of need at the time of the letter of intention, they have to have at least 70% of all of their facilities that they own or operate. So that are owned and operated by the applicant or a related or affiliated entity for 3 years or more. They have to have an average overall CMS star quality rating of 3 or more stars in the most recent 5 quarterly refreshes. And there's some additional data there if you want to read further into it, but basically that is what the current authority is. Those benchmarks that have to be achieved for a CON are only required of nursing homes applying for a certificate of need. They're not currently required of the homes that are applying for an acquisition, and but they are unofficially being used to evaluate the quality of nursing homes that are being acquired. So again, these are topics for discussion that have come up a couple of times in the work group that we're just putting together on one slide to discuss. So some possibilities for robust quality oversight are possibly adding a benchmark for performance requirements on the current nursing home family experience of care survey. We could add additional CMS data such as the special focus facility status, any abuse flags that CMS reports. There's also additional state level data that might be a possibility, such as data collected by the Ombudsman, data collected by the Office of the Attorney General, and OHCQ annual reports. There's also a possibility to require oversight of post-transition activities and requiring or changing some of the benchmarks that I just went over on the previous slide. For example, something like we could modify the 70% requirement, 70% owned requirement. So these are some suggestions. If you have thoughts, we would like to hear them. And Dana Kaufman, you have your hand up.
Yeah, I think on somewhere on this slide, it has to be acknowledged or used as a discussion point on one of the comments that Bob Kramer made with the fact that during COVID for 3 years, the only surveys that were being done was infection. So now you have surveyors coming into facilities, and there are some facilities that have not been surveyed in 4 years, and they're looking back 4 years and 4 years of information, and facilities are getting deficiencies for things that happened 3 years ago where the owner may not even be the same owner. So again, we're looking back, not looking forward. And we have to be very careful because we are going to see a decline in our 5-star rating, which is not going to align with what is the present situation in those homes. So when we look at this, I think we need to put some type of acknowledgement or bullet on impact of COVID on the data collection, because it is going to skew it.
Great, thank you.
I know that this is something that the agency is being thoughtful about. I had, I think, 3 clients affected by this. So for example, we had a situation, and this isn't a criticism, it's just a factual observation of a facility that had some small number of beds, 15, 20 beds, that it wanted to convey and relocate to another facility that was a 5-star facility, that the receiving facility would be a 5-star facility. But because it had common ownership of, I think, 2 or 3 other facilities in Maryland that couldn't meet the standard, they were advised that letter of intent would not be an acceptable letter of intent. I think there's a little bit of, I think Dana makes a good point about the specific window that we're in, but I think there's also the effect, I think I would urge consideration of the fact that I think it's operating almost like a de facto moratorium on CON applications, and for facilities like that. I think I know others have made that speculative observation. I would agree with it. But I would just, this is another area to be thoughtful about, is to there's an old expression, be careful what you wish for, you just might get it. I think there are situations where you would want, certainly if you're dealing with bed relocations, as opposed to if you were building a brand new nursing home, who was going to build a brand new nursing home. I think not all CON applications are alike. And so I just think I appreciate and endorse consideration of the impact of this, because I think it is having a bit of an unintended consequence of a chilling effect on otherwise laudatory submissions that aren't can't be made.
Thank you. Is the MHCC Nursing Home Family Experience Survey on the website. If you're asking if you can look up the questions, yes, the information is on the website, but that's not how people take the survey. I'm not sure which you're asking. People take the survey, we contact them and give them either a link or a paper survey to take it, but all of the information about the survey is on our website.
Thanks. I just wanted to look at the survey to start seeing the questions as it relates to this point maybe including it as a benchmark.
You
just
can find it if, can you put in the?
she put the
you did,
link
okay.
in. Yeah,
Okay.
thank you.
It's already on top of it. Okay.
And Dorinda, the questions are actually listed in the back of the survey.
The reports.
Yeah, right. And I see Ann McKay is agreeing with Dana that their skilled nursing facility had 6 surveyors out for 3 weeks. Which is substantial.
Thank you. Are there any other questions, comments? Okay, all right. Okay, the next, so the next meeting has already been scheduled for September 15th from 10 to 12. You should have received an invitation to that already. If you haven't, please let me know. And in that meeting, we will discuss a little more in depth the 3 and 4 bedroom regulation issue. And we'll get a little bit further into the CMS star quality ratings as part of our current regulations. And then we want to start summarizing some of what we talked about so that we can move forward with talking about generating some recommendations. So if there are no more comments or questions.
So it did seem as though there was interest on what are we going to do with those concerns? When are we going to develop them further in future work group meetings, catalog them as concerns, but not rank them by the level of concern? Or I think I did detect some concern that, how the concerns were going to be addressed and what are our plans. I think people probably want to know that.
We will address more as we go through all of the notes in the meeting recording. We will bring up for additional discussion at the next meeting, because one of the things we want to achieve is starting to summarize what we're learning and talking about. So we will bring up it for additional discussion.
I think there should be some attempt to rank or order concerns.
Yes.
But I think the dimensions on which we do that need to be discussed the work group to make sure there's general consensus.
As much consensus as we can get, yes. Okay. All right. Well, thank you everyone and have a fantastic weekend.
Thank you very much, everyone, for your patience in the initial little glitches, but I think the meeting went very well, and I thought that Mr. Kramer's information was helpful to our continued deliberation on this issue. Have a nice weekend. Second that motion.